Hi there, this is Carmen, and these are the rest of our slides from class yesterday on anxiety. I think we stopped at number 25, which was anxiety travels in company. And really, what I want to bring to your attention here is that even though we're going to be talking about assessing or we've talked about how to assess, and then we're going to talk about coping strategies, and then we'll talk about the different disorders. I think it's really important that you always are cognizant that anxiety often finds company with substance abuse, social withdrawal, and other comorbidities. And the reason that happens is really because a person is trying to cope, and because we don't understand sometimes our lived experience with anxiety. We don't know what's wrong with us, and I used quotation marks right now when I say that. We'll use substances to try to self-medicate, because if we don't go for help to the appropriate places, or seek help from the process, or find the resources, as in we talked about meditation and other ways of calming down. If we don't get that instruction, and we don't know that, then we might use less effective coping strategies, of which one of them is to self-medicate with substances. So it's very common, like 10 to 30% of people struggling with anxiety, for instance, also struggle with addiction, particularly alcohol. So just to keep that in mind. Some of the anxiety theories, genetics show us that there are some links between uh, different anxiety disorders. So if one of your parents has a panic disorder, there's a likelihood possibly that you might also share in that, or the next generation. General anxiety disorder too has been shown to have a strong affiliation with the next generation as well. Phobias, OCD as well. But yeah, I just want you to take a step back for a minute and look at that. That could also be some cognitive behavioral training, in a sense, because you saw your mother terribly afraid of lightning, and therefore when the storm happened, the whole house, the windows were locked, the windows closed. Everyone was afraid. Mom was terribly afraid, and you as a child learned to be afraid. So there's a little bit of that's questioned in the genetics. Biochemically, though, there are also some phenomena with magnetic resonance imaging, as particularly functional MRIs. We can see that the amygdala in a person so that's the center of the brain, that's the fear center, or sometimes called that, and it's also where the brain regulates fear, memory, emotion, coordinates certain other resources with the heart rate or blood pressure. So it has a part to play in that. While people with anxiety are often, when we do functional MRIs, we can see that they're highly sensitive to unfamiliar situation, and they react more readily. So that part of the brain triggers off, uses more sugar. That's basically what functional magnetic resonance is looking at. And uses it much more readily in a person that is dealing already with an anxiety disorder. So there seems to be something there. OCD, we can also see there's a little bit of a change as well in the brain. Specifically, nerve pathways are different with somebody who is struggling with OCD. Also, attention deficit disorder and Tourette's, also there's some changes in the networking of the brain, so to speak. Particularly as it relates to emotion and memory storage areas of the brain. Neurotransmitters, I ask you to take a look at that learning module where we looked at the effects of the different neurotransmitters. That's really a review of your anatomy course, but I just want you to have that sort of fresh in your mind, because, for instance, when we're talking about anxiety, there's changes, and also the medication that we give affect the different neurotransmitters. So having some understanding will help you. Abnormalities in GABA and serotonin are particularly noted in generalized anxiety disorder. So GABA is typically helps prevent nerve cells from overfiring, and serotonin, on the other hand, is important for giving us a feeling of well-being. And in both cases, they're less with people who are struggling with generalized anxiety disorder. So if you think about that, generalized anxiety disorder, we're going to talk about in a minute, is sort of this constant feeling of anxiety or worry. So the walking worried is basically this experience. And so, but if we understand a little bit about the biochemical reaction of GABA and serotonin, and if they have less basically in the synaptic cleft going on, then maybe they are more predisposed to generalized anxiety, because that's the way their body responds to things. So that's sort of what science is showing us now. Post-traumatic stress disorder, there are higher levels, excuse me, just a minute, of cortisol, which is no surprise, and epinephrine. So that they just have higher levels, so they're more reactive. With social phobia, we see changes in serotonin and dopamine as well. And so there could be something. And medications that we use definitely try to impact these levels of neurotransmitters. Sensitivity to CO2 has also been shown to be a response that people with anxiety experience. Many people, including children with anxiety disorders, are very, very sensitive to carbon dioxide. So when they hyperventilate, for instance, obviously they retain more CO2 because they don't breathe out properly, and they are more sensitive to that than perhaps somebody else who would simply be holding their breath, and they would not necessarily have that same anxious reaction. So there's something there. So over time then, what we notice, I'm sorry here, so you can just see that hyperventilation, which causes your rapid heart rates and so on, will just aggravate this situation for a person and cause the very, very nature of their anxiety too. One thing that we also notice is since CO2 is released from the lungs when people exhale, the condition may be aggravated in crowded spaces where you're going to be closer to other people's CO2. So that might be in airplanes or elevators or places like that. So panic attacks or those kinds of things often occur in these kind of, or often people who have panic attacks, they are very fearful of these crowded places, but they might have good reason because maybe they're more sensitive to CO2. That's just an interesting thing to know. Psychodynamic, we talked already about the defense mechanisms. Yesterday, or when I shared with you that Anna Freud, Sigmund Freud's daughter, basically looked at neurosis, which is what Sigmund Freud looked at, which is basically anxiety. We don't call it that anymore, but we did call it a neurotic or neurosis in the past. And then realize that people use defense mechanisms. You could use them effectively, or you could use them maladaptively. And that's when you start running into problems in relationship, which ultimately are the sign or hallmark of a mental health disorder. We'll talk a lot about defense mechanisms when we look at personality disorders, but they also have a huge part to play in anxiety disorders. And being familiar with those defense mechanisms and how you as a nurse would recognize them by a person's comments or behaviors is really, really important. So being familiar with them. But they have a place to play also in this. Interpersonal, as I said, family dynamics, what we've learned and what we've seen in our family, the way our families have deal with stress, deal with anxiety, plays out too. And we learn, so the behaviors that we learn from others plays out. As I already mentioned that with phobia, OCD has a place also with that. Traumatic events. Almost everyone who has experience with anxiety, it's been triggered. Their anxiety event, they can often go back to a time and a place where something happened, and from then on they had anxiety. It is some kind of event where perhaps they felt threatened. They felt that their life was in danger, somebody else's life was in danger. Putting that that, along with these biochemical factors, put it together, makes a person highly susceptible to anxiety. Some medical conditions, although there's no relationship exactly between the medical conditions and anxiety, often, migraines, having problems with sleep, particularly apnea, sleep apnea, when you wake up startled and thinking, oh no, am I going to die? Prolapse, mitral prolapse, also a fear of pending doom and death because of their health condition. IBS, chronic fatigue, the never-endingness of this problem, and you never get a handle on it. Premenstrual syndrome as well. All of these can also cohabituate or foster, these kinds of issues can foster a propensity towards anxiety disorders as well. An interesting one too is pediatric autoimmune neuropsychiatric disorder, or PANDAS as we call it, which are basically following streptococcal infection like strep throat or rheumatic fever, where a child has had that experience and high fevers, and before they were not anxious or they did not have OCD. After the insult, suddenly the symptoms are apparent. That does happen as well. It's not always, but there has been enough to make it a notable possible precursor. So making us think about infection. There's also a lot of research now that's looking into gut flora, which I have not wrote on my theories, but you can hear more and more about if we change the flora in the gut, we have a healthier gut, we seem to have less anxiety and symptoms. Depression as well has been shown to that too. So that's new. That's probably going to be in your career that's going to take off. Good news though. Please hold on to this. Carry this always. Anxiety disorders are treatable. Early treatment can reduce negative effects. What you notice and how you help a person and giving them the tools and is hugely beneficial. So us doing the assessments, very important. The Hamilton Anxiety Rating Scale is one tool that we use. It's basically a 14-item tool where 0 to 4 rates the severity of the issue. Please open up the hyperlink here. It takes you to, I'll just do it real quick. It takes you to a, there it was. I'll just pull this up right here. It takes you to this article, and at the end of it you can actually see the scale, and you can see the 14 items are listed, and then there's a scale of 0 to 4 of this. So you notice during an anxious mood, so we talk about that, we've talked about that, tension, fears, intellectual, the person has very difficulty concentrating, poor memory, gastrointestinal symptoms. You can see all of the symptoms there. A person is scored, and obviously the higher the score is, so the very severe, the 4s, are extremely or grossly debilitating, so absolutely making this person's life very difficult, whereas the mild or not present are not an issue. So just to help. But they help us as nurses to be able to see how debilitating something is. Just want to make sure I got this slide at the right place. Here we go. Okay. So this is a tool you'll see. So now we're going to take a little time to actually look at the different uniquenesses of each of the different disorders, because as you know, this is a family of disorders. Generalized anxiety, for instance, is where the anxiety, what's pinpointing it, cannot readily be identified. It's kind of a low-grade, constant worry, but beyond normal worries. There's nothing, we don't know why it is. It's excessive and it's constant. So it's not panic, but it's a constant sense of worry. And it's persistent, it's pervasive, it's been around for a period of time, over 6 months. It doesn't go away. Okay? You can't pinpoint what it is, but it's always there. Kind of colors the way you see the world. Okay? Typically, this person spends a lot of time worrying. They have issues about the degree of control they have over things. It impacts their personal life, their social life. Often their occupation can also be affected by it. Usually the diagnosis made by exclusion. What I mean by that is that we've ruled out the other anxiety disorders and then come to this one. More common in women than in men, but it is readily out there, 4% of the population. Nursing interventions, your book has great tables. At this point, from now on, I want you really to pay attention to the tables in all of the chapters, because the tables give you examples, for instance, of interventions, and they're very good. And they also give you examples of what a person might say and how you would respond as a nurse. This are hallmarks for testing, because your understanding. Typically in a test, be it my tests or an NCLEX exam, you're going to be given situations, and you're going to have to discern what kind of anxiety are you looking at, what would be the best way to respond based on your knowledge of this kind of anxiety experience. And after you've done your assessment and you've determined what it is, now what's the best response. So these intervention tables are very, very, very valuable. So your book tells you that you combine relaxation because you want to help this person to reduce that tension in their body, right? So relaxation, awareness of their stressors. What I mean by that is, can they identify some things so they can get some control? Have they noticed some patterns? Are there certain places, certain things? Now you won't, again, because it's generalized, it's not like you're always going to identify it and save the day because you've got it, but you will be able to say that I've noticed if you don't sleep well, if this pattern is broken, if you don't go to the gym, if you don't exercise, if you don't burn off this tension, things get worse. So it's in that light. Cognitive therapy also really helps, because often this worry is persistent and we have to break or dispute the illogical thinking, because they say, I'm never going to pass this course. Well, you didn't get to nursing third year with a history of a lot of failures, because you're here. So you must have had lots of successes to get here. Maybe there were some bumps on the road, but you're here. So it's not logical to say that. However, we have to break that pattern. Sleep hygiene is really, really important. Routine, super important. And diminishing stimulants, which will cause that feeling of tension in the body. So especially before bed. So anything that breaks that rhythm. Benzodiazepines used to be the treatment of choice, because remember, this used to be neurosis. And neurosis, we dealt with the benzodiazepines of old, creating a whole generation of addicted people, particularly as I told you about when we talked about history and how, we were popping the Valiums and Libriums like it was candy. We don't do that any longer. That's over. That's done. We realize how addictive it is. We don't do that at all. But SSRIs, so selected serotonin reuptake inhibitors, and selected serotonin and norepinephrine inhibitors as reuptake inhibitors are also the pharmaceutical treatment of choice today, because they are very helpful. This particular table I picked off the internet, and you can kind of see here, it's got a few different medications, different disorders, so that we're going to talk about in the future, in the next few slides, but it just sort of gives you an overview. But really, the reason we use these is because we've talked about the fact that serotonin is really, really important in helping a person to have that sense of well-being, and so therefore we want to make sure that there's enough serotonin in the synaptic cleft. If you go back to that learning module that you did earlier this term that reviewed your anatomy, then these medications would help with that. And again, the norepinephrine reuptake as well. So that's why those meds work. Okay, let me just, so if we go back, what can I tell you? I think, yeah. As just probably to help you too with the meds, from now on too, if you go back to the pharmacological, psychopharmacology PowerPoint that I prepared for you, if you go to the sections of the family of drugs, that will help you too to understand the medications better. So I will, with each class or with each lecture, I will be focusing on a certain family of medications. So the SSNRIs and the SSRIs are the ones that are beneficial when we're talking about anxiety disorders. Okay, so now we're going to talk about obsessive compulsive disorder. So what happens here, this is a severe obsessions and compulsions that significantly interfere with normal daily living. Obsessions can consume a person's judgment to the degree that most of his or her day is spent performing actions in an attempt to minimize severe anxiety. So they've got these constant thoughts, and these thoughts that are in their head which make it so that they have to do something to minimize the anxiety in their body. So that's obsessive compulsive. But just to keep it straight and to help you, obsessions are unwanted, intrusive, and persistent thoughts or images that cause anxiety and distress. So they have a thought in their head. So for instance, fear of losing control. I'm going to lose control. So I should, if I see that woman, I'm going to run up on her and kiss her because I'm going to lose control, or whatever it is. So therefore, I have a compulsion then, a ritualistic behavior that helps me to deal with that obsession. So I immediately look away. So I never look up, but I twitch, or I move away, or I do something. That's sort of how these are together. But some people only have obsessions and they do not have compulsions. But typically, obsession, compulsion, people are doing compulsions because of an obsession. Does that make sense? So they could have unwanted thoughts, but not necessarily act on them, or not act with a ritualistic fashion. But typically, if you have a compulsion, you probably have an obsession underneath there. That's something that you're trying to do, a ritualistic behavior to get rid of the obsession. Okay? Many obsessive thoughts and compulsions are common in OCD. Checking rituals are very common. Objects must be in order. You perform motor activities in a rigid fashion to reduce attention. You have to arrange things perfectly, those kinds of things. I'm going to add to your vocabulary FOMO, so the fear of missing out, which is some of the eye disorders are now thinking about. So that's as a result of technology, that sometimes perhaps there's obsessions about, I'm fearful that I'm going to miss out, so therefore I have to check my Facebook all the time, or I have to check the minute my phone beeps, I have to check it, I can't turn it off. And these sort of set the tones for, or set the stage for obsessive compulsive disorder. Okay. So some of the specific care that we can provide people who are struggling with OCD. To begin, I think it's really, really important that you understand that you're part of a team, and the staff has to be consistent in their expectations and acceptance of patient behaviors to keep the person with OCD from becoming more frustrated. Because if they become more frustrated, that's going to fuel the fire of the anxiety and the tension. So there has to be consistency in the team. Know that individuals do not consider their compulsions pleasurable. I think that's very important, because they're not happy to be doing this, and they're very upset that they're caught in this. And each time they do it, their sense of control is diminished. Each time they do it, they feel less value in a sense. So it's not something they want to do. And when they resist, though, then their tension, if they don't do their compulsions, then they have a higher sense of, then on the flip side, they have even higher anxiety that just festers and exacerbates to the point that they have to do it, they have to release. And then when they finally do the compulsion, then they feel terrible for doing it. So it's a very negative cycle. So be aware of that. And so, you know, as a nurse, have compassion for that, because it's a very troubling place to be for someone. Obviously, if there's any of their compulsions are in a situation where it causes harm to them, I mean, it could be skin integrity, it could be pinching, it could be banging, it could be lots of things. Our role is to minimize any possible harm to them. Good. Then next, sorry. So as you can see, if it's biological, joint, care of joint, if a person has a particular obsession where they move their head quickly, or they wash their hands a lot, this can all have biological ramifications, as you can see there. The type and severity of these obsessions needs to be assessed. So typically, we won't start with a direct question. It'll be an indirect correction. So asking a person, because they're well aware of their obsession, so telling them, like, you know, how often do you do this right up front is probably tough, but you could say, how long does it take you to get dressed in the morning, to leave the house? Does anything of your pattern impede your getting to work? And you'll find often that these obsessions impact, you know, their work life and everything, making it difficult. Then you go to more specific questions. Do you find yourself frequently returning to the house to make sure things are turned off or turned on? Those kinds of questions. I'm just going to share a little story here. My own nephew suffers from OCD, and his OCD was one of perfection, that he had to have the letters always perfectly lined up when he was in school or in math or stuff like this. And it sort of happened, there was a lot of things happening in his life, and he was trying to get control of things happening in his own family and his own life. And it happened, you know, basically when he was in grade 11 was when it first started to manifest. And he would go in and he'd write a test, and if everything wasn't lined up properly, a math test, he would erase it and then rewrite it and then erase it. So he never got the questions written, and they were never finished. And so, you know, he was deemed as not able to do it, but in effect it was his obsession with having everything line up in order to be correct was actually the problem. So just to sort of tell you a lived experience, and that had huge ramifications for him, because he didn't finish high school. He had to go back later. So it's just so sad. It's tragic. Some of the psychological ramifications, how do we nurse somebody and help them? Response prevention. Presented with situations or objects that are known to induce anxiety, and asked to refrain from performing ritualistic behavior. So what we mean by that is, response prevention is helping a person. We don't do this the first day. This is not when you first start working with a person with an OCD, but as you are working with them and as your therapeutic relationship builds, then we could start to say, can you not do that ritual? Can we delay you doing that ritual for 5 minutes? You will get to do it, but can we delay it? Can we slowly delay it? Or can we do it less, not as long? Or can you check that once? You know, those kinds of things. So response prevention. So that's what that is. So, but that comes with a therapeutic relationship. Thought stopping, that's interrupt the obsessional thinking by saying stop. That, like we learned with our hearing voices that are hearing voices that are distressing. Thought stopping, having to stop that thought, or using other means, music, other things to stop the thought can help too. And so we have to teach that. Relaxation techniques, hugely beneficial. Cognitive restructuring. Examine the distorted thinking, the automatic thoughts, and then explore where the incongruence is between thoughts and reality. You know, you will not lose control by you will not have to act on that thought that's in your mind that says you'll lose control and you will go and hit that person. You won't have that, won't happen, and these are why this won't happen, and you work through it because you've never done that, it's never happened, etc. So we work with that. Okay. And other nursing interventions on the social, we have to consider the social culture factors, so we have to understand that because there are, we have to understand everybody's health, everyone's stress response within their culture. In the hospital, unit routines are carefully and clearly explained to decrease patients' fear of the unknown. This is the person that needs to know what's coming next, and you have to stick by it. And you have to work with the team, because if you put them in a situation where the fear of the unknown can start to fester, then, which a hospital easily does, then things get worse. Recognize the significance of the ritual. That comes with time. That doesn't happen right away, but with time, with a therapeutic relationship, we might come to realize that some of the rituals are being done, are there because are there because that was part of that trauma as it started way back when. A sense of uncleanliness might go back to some traumatic event. A sense of needing to wash the hands or wash a body part or something might be related to some trauma. Maybe not, so don't jump to conclusions, but there could be some significance to the ritual. And then once we know that, then we can work on helping work through the trauma. But that's long term. Assist the patient in arranging their schedules, because again, often these experiences make it difficult for a person to work or function, so we need to help them to possibly arrange their schedule. So this might be, especially at the beginning, when I'm developing a therapeutic relationship with the patient and I know they have OCD. I'm not going to tell them to stop doing what they do, but I will warn them that lunch is at this time. We will be going to the cafeteria or whatever, or there's an expectation to be at an appointment. So therefore, you'll have to arrange your schedule so that if you need to have some ritual or some part of your ritual, maybe not the entire ritual, part of the ritual, we have to put this in time because you do have to meet this timeline. So those are where that's coming from. Okay. Treatments, could be CBT, very, very incredibly good. So that's cognitive behavior therapy. Again, that's breaking those automatic thought behavior connections so that slowly a person, those automatic thoughts, those compulsions, those obsessions can slowly be mitigated with time as we break that cycle. And CBT is very good with that. Exposure, that is, if a person needs to do a ritual, we slowly, or they're fearful that, they can't tolerate dirty touching things because if they touch it, they'll be contaminated. Then we slowly have them in a place where they can actually put their hand on the desk, because a public place, a public desk might be seen as an absolutely terrifying place for somebody with OCD. But we will say you can touch it for a moment. You can touch it for 10 minutes. You can touch it without needing to use Purell every time. You use Purell before you eat, but you don't have to do it all the time. That's sort of exposure therapy. Ritual prevention is, as I said before, can you tolerate longer periods of time without doing the ritual? That's sort of what we do there. So exposure is touching the thing that's offensive or whatever, whereas ritual prevention is slowly breaking the routine of having to do the ritual as often and as frequently as you did before. Deep brain stimulation is more recent research. In very extreme cases, that might be done. That's new research, a lot of new research, but it is showing to be beneficial, especially for people who, as I said, very severe cases. It's and treatment resistant, so people who don't respond to CBT, exposure therapy, ritual therapy, or anything like that, they might be involved with deep brain stimulation. And it is very effective. 60% of the people who have it, of the people who have it, 60% speak of improvements, but it's only used in very, very severe cases. Okay. Medications that are effective, SSRIs are. They are beneficial, and also Effexor or venlafaxine is also beneficial. What's interesting about Effexor or venlafaxine is small doses affect serotonin, medium doses affect norepinephrine. That's from their psychopharmacology slides. And large doses affect dopamine. So you can see how this medication is used in different ways for different things. So in small doses, it is effective with OCD. And you always have to watch the side effects, obviously, because the side effects of these medications can cause people to feel uncomfortable. They might feel more lethargic. They might have issues of alteration in bowel regime or things like that. And those same symptoms from the medication can be interpreted as somatic concerns, which would then bring on more of the obsession. So that's really important to know too. So just to pay attention to that, which might fuel that. So you have to really do a lot of teaching about medication. Post-traumatic stress. So let's talk about that one. It affects about roughly 8% of the population. Again, this is a result of a trauma. When we deal with this in terms of people who are first responders or soldiers or nurses or emergency paramedics, those kind of people, we might refer to it. Sometimes it's post-traumatic stress, sometimes it's considered operational stress. Operational stress because it happened at work. Post-traumatic stress is because it's a trauma. So you might see the words, depending on what population, you might see these two words used either word you might see. What else can I say? It could be a result of a trauma, so ranging from 20% after a motor vehicle accident, people experience post-traumatic stress disorder, and 80% of prisoner of war incidents. So you can see, depending on what a person experiences, the incidence is higher. A person doesn't only develop after a personal experience, but may also be because they have been traumatized, but because they've seen somebody else been traumatized. So they're not necessarily the victim, but they have seen somebody else, and that also causes post-traumatic stress disorder. Individuals with post-traumatic experience four things. Re-experiencing, they constantly relive the experience. They also have a great desire to avoidance, because putting themselves in any situation that triggers off their trauma or reliving their trauma is very frightening. They have numbing, which is their mind just puts this event out of their mind, or they don't respond to emotions, neither joy nor fear nor anything. They just numb. And then they're heightened arousal, so they're very hypersensitive to sound or to noise or sensations. That all plays into that. Okay. Extreme response. Let me just think here. Okay. So again, this anxiety disorder is an extreme. The person experienced with post-traumatic stress from the last slide, they experience extreme helplessness. They persistently have recollections, dreams, hallucinations, flashbacks. Flashbacks are a hallmark of post-traumatic stress.
and they exhibit impaired social functioning. That's what we just said, withdrawal, and then numbing of general responsiveness. They just don't respond. So this is difficult when in relationship or so on, because generally they don't respond to the love or the care or the emotions as they should, typically would have, and if they had not had this experience. Another factors that contribute to post-traumatic stress or occupational stress are the trauma, naturally the nature of the trauma. Fatigue. What was their state when the trauma occurred? So all of us, you'll be working in situations where you'll see trauma. But if you are in a healthy place when you encounter that trauma, either as witnessing it, walking alongside, as a nurse, or perhaps something that happens, if you're in a place where your self-care is high enough or you're well enough, then you can deal with it because you have the skills and the knowledge. But if you're fatigued, then you can't. And so just thinking about the war situation and the soldiers, they're in situations where they're very fatigued and then trauma happens. They set the perfect stage for post-traumatic stress. Grief also is a factor in this. The loss or injury of someone you cared for or somebody who is very dear to you, the nature of that relationship and the amount of grief it causes you also contributes to your experience of post-traumatic stress disorder. So if you're in a car accident, for instance, you witnessed a terrible trauma, and your person who's in the car with you, your loved one, was killed, the grief, it was terrible, the nature of the accident was terrible, but the grief that you experience at that loss can set you up for post-traumatic stress. Just the stage is there. Moral injury is a very interesting one, and there's a lot more research that's talking about this, is that if this event that happened, this trauma that you witnessed, put you in a place where your own moral conscience was threatened. So you felt you could have acted. I was driving the car. I could have done something different. Why did I do this? Why was I driving 5 kilometers faster than the speed limit? I should have never done that. So these moral injuries, if that's included in the story, or if you're in a situation where you're a soldier and somebody was killed and you could have prevented it, or you think you could have, or you think that the situation was such that it wasn't what you would have done in good conscience, then anytime there's moral injury, that just fuels the fire for post-traumatic stress. Okay? So that's part of that. So the concept of moral injury emphasizes the psychological, cultural, and spiritual aspects of the trauma, how it affected you. So in this image right here, these are the former St. Louis police officer Jason Sakely in 2017 was acquitted from the shooting death of Anthony Lamar Smith, who was a young person of color, and that caused huge ripples in the police force and all kinds of issues, and people really questioning roles, and then having to be police who would stop protests, and it was just a horrible moral injury for everyone involved. And so those kinds of situations just breed the opportunity for post-traumatic stress. Treatment, well, several past and present focused treatments are part of this. The past treatments emphasize repeated exposure to the memories and emotions of the event in order to diminish their impact. So that's called exposure therapy once again. So as the other exposure therapy was more, putting yourself in a situation where you live that experience, and it's the same principle. Now this again has to be done with a therapist, and very well, because the reason that past trauma has to be dealt with is because it has to be processed, because when the trauma happened, your sights, your smells, your everything, it all happened so fast that you couldn't process it. You just knew that when you woke up from the car accident, your husband was dead, And but you remember the sights, the smells, the crash, the sound, but you don't remember anything else about it, and you have to put it together, because anytime you hear those sounds or anytime you get in a car, your emotions, your stress just goes through the roof. So we have to we have to expose you in smaller bits to that situation, and then slowly you become comfortable again in those situations. My work here, we're here in the city of Ottawa at the Royal. They have an operational stress injury program, and there's been amazing research, and the exposure therapy is a huge part of it, where you bring the soldier back to Afghanistan, not physically, but in pictures, in the smells, in the sounds of Afghanistan, and then you slowly walk through, and you literally have the images of what it was like there, and then they've actually shown that if they have the soldier walking towards the images or the sounds and the smells, and they're physically processing this, and then you slowly walk them through and you say, what are you feeling now, what are you feeling now, and how do you understand what's happening, then slowly you can help mitigate the trauma that they experience, or they process the trauma, and they also process what they could and could not have done in that situation. Present focused ones are really dealing with coping skills to improve functioning. That's really what that's about. So breathing, anger management, all of those kinds of things. Medications, yes, again, SSRIs, tricyclics might be part of it. Antipsychotics, because remember, with this disorder, you see the hallucinations, you see the flashbacks. So in those situations, the antipsychotics might help. So you want to know what's part of that story. Mood stabilizers, if this person experiences rushes of emotion, they get very angry, those kinds of things, a mood stabilizer might be good. Service animals, and there's a link there to a video, are very beneficial as well, and help as well, have been shown to be very helpful. Okay, acute stress disorder is yet another. You can see that in your book, and this basically is, they share the same symptoms, clusters as post-traumatic stress, but it's really only over, it differs in duration, and symptoms emerge 2 or 4 days after exposure and last for about a month. Post-traumatic stress can come months, years later. This is really something that comes right after the event. So right after the car accident, 2 days later, you start to experience this acute stress experience. Looks like post-traumatic stress, but it doesn't last. After a month, it starts to dissipate. Okay, a person though here might experience symptoms of dissociative symptoms, or where they involves disruption of their consciousness or their memories and their awareness of their perceptions. They don't even remember the accident. They don't remember what happened. They don't remember how they ever got there. They have absolute disassociation. So that could happen. Depersonalization, on the other hand, is a state where one's thoughts and feelings seem unreal or not to belong to oneself, or they have a sense of losing their identity. That happens also with acute stress. So in that time period, they can't remember what's going on, or they might not even feel like their emotions or their thoughts are theirs. That's not me. It's not me. This isn't me. So those are depersonalization. You might have that experience. Okay? Yeah, there's some controversy if acute disorders should be considered post-traumatic stress, but for the purpose of us and our studies, acute stress disorder is a short experience of post-traumatic stress, and usually there's disassociation can be part of it. Okay. Panic. Now, panic disorder is a lived experience that many people experience. These are discrete episodes of intense anxiety. So whereas GAD, or generalized anxiety, is constant, post-traumatic stress is reoccurrent, but these are discrete periods. Person is going around, everything is fine, and then out of the blue, out of nowhere, these discrete episodes of intense anxiety that is absolutely debilitating. They peak within minutes, and like in 10 minutes it's passed, but during that 10 minutes the end of the world was there. It really feels that way. Extreme palpitations, sweating, trembling, chest pain, choking, nausea, cognitively depersonalization, which we just talked about before. They also have derealization, which is at this point, whereas with depersonalization, the person internally feels like their thoughts and their feelings don't belong to themselves. Derealization is that the surroundings around them are not real, and they feel they can't connect, like they don't know where they are, but they also, when they look around them, they cannot, they don't feel like this is real. This isn't happening. This is not real. Being in this room, being in this elevator, this is not real. The surroundings are not real. Okay. Fear, they absolutely have a fear that they're losing it. I'm going to use that term rather than crazy, and the absolute fear that they're going to die. As you can see, quite a significant population have this in their lifetime. There's a strong association with depression and substance abuse as well with this disorder, because that co-current kind of thing. Because if you have panic disorders and they come out of the blue, and they fear, and the fear is unbelievable, it will put you in a place where you can have depression, because you will be fearful that this will happen. My life is coming to an end. These attacks come out of nowhere. So depression is, again, a partner in this experience sometimes, and substance abuse to try to mitigate the issues. So just to know that. Genetics, as I said before. So what is a panic disorder? It's an extreme, overwhelming form of anxiety when an individual is placed in a life-threatening situation. But that is real or perceived. The person perceives this situation as life-threatening. You might not, but they do. Or I might, but you might not. It's what the person perceives. A normal panic becomes abnormal when panic is experienced routinely and when it is generalized to situations that do not normally pose a threat. Typically, the first panic attack happens as a result of something that was worthy of panic. Car accident. I have a dear friend who has panic attacks, and her first panic attack, she recalls, was in a chairlift going skiing, and she felt it had jerked. Sometimes it does. As chairlift, anybody who's a skier will know that. And she felt like she was going to fall off. She didn't fall off, but she had an extreme sense of panic. From then on, that continued, and she had that again other times skiing. She would just have a panic attack. Then it happened in car driving, over bumps or things. It just kind of went a heightened sense of panic in lots of situations, and they would come out of the blue. Like sometimes there would not even be that bump or that jostling or that sensation, and then it would start. It's a chronic condition, typically with exacerbations and remissions. It is characterized by the appearance of debilitating panic, with or without agoraphobia, so without the fear of crowds and being in social places. Both kinds of panic disorder, with or without agoraphobia, include recurrent, unexpected panic attacks followed by a month or more of consistent concern about it. So even though you have the attack and it subsides and you no longer have the shortness of breath and the feelings, you are fearful that another attack will come upon you. And that persistence is what also adds to the debilitatingness. As I said, the panic attacks, there's links between agoraphobia. So because of the panic attacks, people then feel they become fearful of situations or phobias of being in public places or out in groups or in any fear of people, etc. It just amplifies. How to help a person experiencing as a nurse. We begin by determining the patterns of the panic attack, the symptoms and the responses. So how does this manifest itself for you? This may be difficult to identify specific triggers because that's hard to do, because the very nature of a panic attack is its coming out of nowhere experience. But people do know that, again, those qualities of not setting yourself up for fatigue, eating well, exercising, dealing with the pent-up energy, dealing with conflict, all of those things, finding constructive ways to deal with that, all of that helps. The kinds of things you'll notice with assessment, you'll notice restlessness, irritability, all of those kinds of things. Always do a suicide assessment as well, because panic, in the state of panic, or a person who is dealing with panic attacks, and especially if they're in this negative depression cycle, they might see that there is no alternative to their situation except a very drastic to harm themselves. So that's really important. Panic disorder, like other forms of anxiety, very, very responsive to cognitive behavior therapy. So again, assessing and working with understanding their interpretation of the catastrophic misinterpretation. I'm sorry, I jumped to intervention rather than assessment. But assessment, we want to know what is their catastrophic thinking, what do they believe is going to happen, and then our therapy will be to once again deal with the thought processes that are leading them to this. Breathing control, very important. Relaxation techniques, nutritional planning, encouraging physical activity and sleep. Very, very important in disorder treatment. At the point of crisis, though, when a person is having a panic attack, none of this will work. All of this happens outside of that time, when a person is not in a panic mode. Then, because remember what we talked about when we talked about the levels of stress or anxiety, when a person is in a panic mode, you can't teach them you can't even tell them, now breathe. It's really, really hard to do. At that point, you just walk alongside of them. You can't teach them breathing techniques, but you can be with them and keep them safe. That's what you can do. But the treatment over time of what we would do for panic disorders is teach these the health and well-being surrounded with these things. Okay. Okay. You might see other interventions, though, when we're doing interventions here. Again, distractions. If a person is starting to get anxious, distraction might work, might not. Counting down from 100, positive self-talk, I will get through this. Psychotherapy, as I said, is very, very beneficial. Cognitive behavior therapy to break that cycle of the automatic thoughts which bring the behavior, which bring the sensation of being out of control. That's very, very important. Panic control treatment, also, this is also done outside of, not when a person is having a panic attack, but here too, what we try to do here, the education around this is it combines education, cognitive interventions, relaxation and breathing procedures and exposure techniques. It's all together in a panic control treatment. We try to demystify a panic attack so they understand it, what's happening to them. They will not die, but they will feel like they will. The physical components, that they understand what's happening in their body, the cognitive components, that they understand irrational thoughts, behavioral components, that they understand the things that they do and how avoiding certain situations, but not to the point of developing phobia, but not setting themselves up for a panic attack until they have the strategies to be able to deal with it. Okay. That's all part of panic control. And in exposure therapy, as I said before, that's really, again, when a person, not when they're in a panic attack, but we slowly, my girlfriend, for instance, still skis. She skis, but she had to slowly build up again her confidence to get on a chairlift because that was gone, right? But she slowly was able to build with therapy, working with people, and also having, what was really interesting for her, I talked about sort of significance of certain items or things like that that are kind of, they give you courage. We talked about the stuffed animals for kids or stuff like this. Well, in her situation, she always carried a little, it was actually a keychain that was hanging on her ski suit and that on her ski jacket, and she would hold that and clutch that because that had significance. It had a spiritual significance for her, and so that made it possible for her to do that. And so that was slowly exposing her more and more to the chairlift, and then before you know it, she's going skiing still. So it hasn't debilitated her completely. Systematic oh, wait a minute. Systematic desensitization is you build it, that's in slow steps, whereas exposure is all out. I should really walk you through that. Oh, I did not do that. Let me go back for a second. Previous. Yeah, okay. I just want to make sure. Let me explain that right. Let me go here. Okay. Exposure therapy, what happens with systematic desensitization, it's in slower steps. Exposure therapy tends to be a bit more drastic. You know what it is, and you build them. Where systematic desensitization, we actually use that more with phobias than we do with yeah, I don't know why I have that on that side, but okay. Exposure therapy is more, we know what the issue is, and we expose the person to that place. So my friend is on that chairlift again with the company of her therapist or her loved one, in her case her husband, who was going through therapy with her, and together they did that. That's exposure therapy. Systematic desensitization would be, okay, we're at the ski hill. The first time we're going to go on the baby hill. We are going to walk up with our skis. The next time we will use the T-bar, okay? We're going to slowly do it that way. Then from then, we're going to go on a chairlift, but a very short lift, very, very short. Then we'll go on a longer chairlift for a longer period of time. Then we'll go on the gondola. That's systematic desensitization. Exposure is you get on the chairlift, but you do it with your therapist, your loved ones, your tools of coping. Systematic desensitization is small steps towards the fear that you had. One example is systematic desensitization is you're fearful to drive. You had a car accident and you have panic attacks now in the car, so we slowly expose you or systematically desensitize you and that happened on the 417. It happened on a highway, on a big highway, your accident. So what we do now is we put you in the car, we go for a short ride, but we go on a country road. Then we go on a 2-lane road. Then we go slowly, we move up until we're back on the 417. Exposure therapy is we would get onto the 417 right away, but we would do it with therapy and support. I hope that helps you to see the distinction between the two. If you have any questions, please talk to me. Okay. Next. Why is it next not coming? Next. Here again, SSRIs are very beneficial. Usually the first line of treatment, we try to use those. First, usually a person experiences some clinical relief within 4 to 6 weeks with these medications. They too might cause feelings of overstimulation when irritated, but we slowly titrate them up, so that's important. Higher doses, some patients will find the medication very sedating and they don't like that. So that's important to know. Weight gain is also a deterrent, and often people do not want to take the medication for that because it's a long-term use. Benzodiazepines are part of that story sometimes, because again, the short-term nature of the medication, it can be used, but again, always watching these medications. Usually we initiate, when a person first has panic attacks, we initiate with benzodiazepines until the antidepressants, the SSRIs, start to work. Usually we use short-acting. Lorazepam are usually short-acting, but be very careful with rebound anxiety, because what happens with these medications, the medications themselves, when you're using them, and you, Ativan for instance, you use it, and when you come off of it, when it leaves your body, the medication itself gives you a sense of anxiety. That's the rebound. So it's not your anxiety, you're getting anxiety from the medication. So you have to be careful with the benzodiazepines in that way. Avoid if the patient has any sleep apnea, because they do cause lower rates of respiration. So that's important. Do not seize any medications abruptly. Side effects can include headaches, confusion, dizziness, and that will of course add to the anxiousness, because these bodily experiences make us feel more anxious. And always do lots of teaching, avoid alcohol, and discuss the sedative effects during a panic attack. So this is all of that teaching, all of the medications, all that stuff happens outside of the window of a panic attack. Once a panic attack happens, you stay with the patient, you reassure them, you do not leave them. You might have to give them clear directions, like sit here, I'm with you, those kinds of things. If they need to walk or play, stay with them, but don't necessarily touch them, because that could aggravate their situation. Stay with them. They might be administering PRN. Allow the patient to vent his or her feelings throughout the experience, and especially after, because that will be very, very important for them to process their experience, and to not harbor feelings of I'm less than because I've had this experience, or those kinds of things. So super important that you let people speak, because they will feel out of control, and feeling out of control is often the biggest threat to self and self-esteem. Very, very important. Social phobias, these are all phobias for that matter we'll talk about, but just to know, these social phobias involve persistent fear of social or performance situations. Exposure to a social or performance situation almost always provokes some anxiety, but in these situations it can trigger panic attacks. So be aware of that. And here again, sometimes people get judged for being incapable. Children, well, if you didn't get on the stage and sing, you're not very good, etc. We have to be really sensitive to this, because it's a lot of people's issue. Many, many individuals have these issues. Regular phobias are, are also there and persistent. About 14% of the population have some kind of phobia at some point in their life. So that's pretty important. Exposure therapy works wonderful for this. Medication does not. We do not use any medication with phobias because it's pointless, but we absolutely, exposure therapy is the hallmark. And usually it's done in increments, where we do it by desensitizing a person. So we don't put the spider on the person's hand the first time, but we might show a picture of a spider, but it's some distance away from the person, and then we slowly move the spider in the jar closer to the person, and then we have the spider, or it's a picture of a spider, then it's a spider in a jar, and then at some point in time it's a spider on their hand, if it ever has to get that far. For most of us that would already be too much, but you get the sense that you're desensitizing the person over time. All right, next. I just wanted to also share you a little bit about substance-induced anxiety, to be able to distinguish the two. That's going to be important in your practice. Substances themselves and using substances can cause forms of anxiety. The withdrawal after a person has had a substance, and then they're in withdrawal, and that causes anxiety. So paying attention to what this person's experiences is really, really important. And we categorize and our care is dependent on, is this anxiety? Is this substance-induced anxiety? If it's substance-induced anxiety, then obviously we want to know, did it happen when they were on the substance? Then they stay away from the substance. But if it happens because of withdrawal, then that could have other implications for a person. That might malinger, that might stay on actually after, if it happened during withdrawal. For instance, that it maintains, it stays on after, and then that causes them to have anxiety from that moment forward. So just to pay attention and to know how it started, what was it, that's part of your assessment. Also, always distinguishing anxiety from delirium, because that's two different things. If a person is experiencing withdrawal, I mean, we might use medications to reduce the incidence, to improve or mitigate the negative experiences of their withdrawal. And so that might mitigate also their anxiety experience. But as I said, there is incidence of OCD, or obsessive compulsive, after a person has had an anxiety symptoms, and particularly if they showed up with withdrawal and they continue. So that does happen sometimes too. So just, that's all part of it. Behavior therapy is usually how we help people as well, but medications might also be part of the story, particularly as they are coming on the other side of withdrawal from the substance abuse, or especially if addiction is included in there. So just, okay. Oh, there's still a couple more. Somatic disorders. Okay, this is chapter 23 in your book. These are basically when people manifest, or anxiety manifests in thoughts, feelings, and behaviors caused by excessive worry about physical signs and symptoms. So whereas GAD is anything in the world, this is physical symptoms. So this person is experiencing a pain, or a sound, their stomach is gurgling, and they interpret that as something very serious. Or a headache is interpreted as brain tumor. Now, always in these situations, the physical possibility of what this is has to be ruled out. So, they will have tests for cardiac issues. They will have blood tests. They will have maybe even a CAT scan. They'll have all these tests. And once everything's ruled out, we might be left with it being a somatizing disorder. And then how do we deal with that? We might be dealing with that with medication. We'll definitely be dealing with talk therapy. We'll definitely be dealing with CBT to try to help a person. This is much more common in women. However, it does manifest in men as well. Also, what this person often experiences, which is tragic, is healthcare providers who become very frustrated with them, and this leads to very poor health outcomes. So the person, because they are experiencing all these symptoms and thinking that they have something else, some cancer or something else, they show up at the clinics a lot, and then they kind of get labeled, and then they don't get care. And then often, though, they have other issues, and that aren't looked at and or are mitigated. For instance, I remember a case of somebody who had kidney stones, but they really had the kidney stones, so they had this pain, but they had other stress related pains before, and then they show up with kidney stones, but of course everything was denied, and it's them again, and they lived with horrible pain until they finally realized they actually did have kidney stones. So that's where the poor outcomes. So just to know that. Conversion disorder, or functional neurological disorder, which is what it's called now, is in this situation a person also, because of an extremely stressful situation or an inability, they're carrying lots of stress, and they can't act on it. I can give you an example. I've shared it in class already about a girlfriend who, the nurse, she does everything for everybody. She's super, super helpful. But she's really burnt out. Like she's absolutely burnt out, and in order, she needs to go out of town to go take care of her parents, and but she just can't physically do it. But she can't say she can't do it. So then she develops a physical impairment. She cannot walk. She's and they think she has a stroke. They rule out all kinds of stuff. They're looking at neurological disorder. What the heck's going on with her? And then they realize that it actually is a psychological in nature. This too is far more common in women, 2 times more likely. Another common, something you might notice with this is label indifférence is a symptom where a person has these debilitating, they can't see, for instance, and yet they're not really upset by it. They suddenly can't see and they're not upset. And that just seems very odd for most of us, but you do see label indifférence with a conversion or a functional neurological disorder. They just don't seem terribly upset that they can't walk, or they don't seem terribly upset that they can't suddenly see. So that's, in these situations, you always have to also assess the situation, but also assess primary and secondary gain. Now that's why that's important, is we have to know why, what for my girlfriend's situation, what does she gain by not being able to walk? I know that sounds weird, right? But you have to look at that, because psychologically there is a reason why this is happening. It's a coping strategy. A debilitating, extremely debilitating one, but it is a coping strategy because life is so stressful. She's in a great place now. Things are much better now, but we needed to explore that. So what are those primary and secondary gains? What are they gaining from this situation? Hypochondria, or illness anxiety disorder, that's when misinterpreting physical sensations. So the stomach, the headaches, or those kinds of body sounds that are normal are suddenly seen as a serious illness. I can't, my heart, I hear my heartbeat, it's a heart attack, but it's not, but they just notice these, so their body sensations are misinterpreted. So they are normal body sensations that are misinterpreted. Okay? What we have to do here, these are same between men and women. They're preoccupied with fear and serious illness, so that's really what the obsession is. It's somewhat of an obsession, and you have to build trust. You have to help a person with their stress management, because there's often gets worse under those situations. Antidepressants might be very, very beneficial, and sometimes even antipsychotics, depending on how they're interpreting. Are they having delusions? What's going on? So if they are then somatic delusions, then we might have some antipsychotics on board. Okay. And lastly, I just want to touch base on somatoform and factitious disorders. So this is when, and being able to tell the difference. Don't confuse somatoform disorders with factitious disorders. What we mean by that are when a person, for instance, takes medication willfully, takes anticoagulants so that they produce blood in their urine, so that they could have a particular test, which mean they would get care in the hospital, or they take medication which will cause certain symptoms, which will get them into the hospital or get them care. That is another disorder unto itself, and there's that is also a mental health concern, but that's not what somatoform disorders are. So just to know that. So just not to mix up the two. Okay? Now I'm going to do a little bit, self-care. Remember to always take care of yourself. The things to do, take back your life. I think that's really important. Going back to those articles that I told you about technology, make sure you take care of yourself. Don't stress yourself if that's the one, or whatever it is in your life. Make sure you do that. Exercise, relaxation techniques, take care of yourself, eat well, reframe your life. Don't look at things necessarily from half empty, but half full. See the positives, look for the positives, laugh a lot, look for the good things. You have to look for them. You really, really do. Create a memory bank, store those positive thoughts, those positive images, maybe on your phone, wherever it is. Just have them handy. If you need them, go back there. Those are the kinds of things you can do. I want to do a few questions with you because I know that you guys want this, but I'm also supposed to post these. So, how to reduce your anxiety. Okay, so let's try some questions. During an assessment, the nurse finds that the client is trembling, restless, BP, and pulse are elevated. The client reports shortness of breath, loss of appetite, and an upset stomach. They are agitated. The nurse concludes that the client is experiencing what level of anxiety here? So I'd like you to look at this and to think about this. Okay, so what do we know? Is this moderate? Is this mild? Is this moderate? It's probably more than that, right? Is it severe? Is it panic? They're trembling. Their pulse is high. So it's probably severe, but it's not panic, right? Because severe, in a panic, they would have dread, and they would have immense fear of death, those kinds of things. There's nothing like that in this story, right? So it's not panic. Okay. During an assessment interview, the client tells the nurse, "I can't stop worrying about my makeup. I can't go anywhere unless my makeup is fresh. I wash my face and put on my makeup at least once an hour, maybe twice." The nurse's priority should be to adjust the client's care plan. Okay, first of all, what do you think is going on here? We're probably dealing with some kind of obsessive compulsive issue here, anxiety, and a manifestation as OCD. The priority here should be what? To adjust the client's care plan so that the client will be required to spend time out of a room, given advance notice of approaching time for all group sessions, asked to keep a diary of her feelings experienced if unable to groom self at will, allow to use own cosmetics and grooming products. Well, first of all, I hope that D is always there. I don't think that's a priority. That better always be the case. Really, the room has nothing to do with this, really, right? Now, this is during an assessment interview. So that's the important item here. So if it's an assessment interview, we're learning something about this person. We're learning about this person at this point too. So we can assume it's earlier in a relationship. So here, giving advance notice about the approaching time for all group sessions, or what's expected and what's going to be the rules and the norms of the hospital is really important in this situation. So B is the right answer. Keeping feelings unable to groom themselves at will, that's really long-term kind of therapy, and you know what, we might not even get to the answer of that. We might not ever even get there. So in terms of your nursing priority, B is the best option there. The nurse is caring for a client with post-traumatic stress disorder. Which statement by the client would indicate the most improvement? The most improvement here. So I'll let you look at this for a sec. So that I am responsible for what happened to me. I enjoy being back at work with my friends. I like to stay awake all night. I can't relax. I stay alert all the time. So you're looking for improvement. Okay. So, okay. It's post-traumatic stress, right? A person with post-traumatic stress, and I am responsible for what happened to me. Remember, we're dealing with a lot of moral conflict and concern and things like that. This person never has a problem not taking responsibility for things. Typically, they take everybody's responsibility and more. It's their fault. So that's not a great response. That doesn't tell us they're getting better. It tells us probably about their experience, and it's kind of almost expected. I enjoy being back at work with my friends. That's good. That's a good one. That could be improvement. I like to stay up all night. No. I can't relax. No. So that sort of helps you with that. Which goal for nursing care plan would be most appropriate for a client who has been diagnosed as having GAD, so generalized anxiety disorder? So we're looking for which goal for the nursing care plan is the most appropriate. Okay. So I'll let you look at that for a minute. Okay. Is it that the client will describe disassociated experiences? The client will display the ability to cope with mild anxiety. The client will relive the traumatic event. The client will verbalize a sense of control over ritualistic behaviors. So for all of these answers, you have to have an understanding of the different disorders. So, GAD, do you experience dissociative experiences? No. That's an acute stress or anxiety experience. The client will display an ability to cope with mild anxiety. Yes, that's for sure, because GAD is a constant sense of worry, but it's not extreme. It's always around though, but it's not extreme. It's mild, it's constant, it's always part of your life. So if you can deal with mild anxiety, you're making some improvements. The goal with the client will relive the traumatic event. That's post-traumatic stress in that sense. The client will verbalize a sense of control over ritualistic behaviors. That you're looking at OCD. A client is experiencing a panic attack. Which of the following actions by the nurse would be appropriate? List all that apply. Speak clearly and firmly. Restrict the client's physical activity. Use short, simple sentences. Remain calm and serene. Teach cognitive restructuring skills. So what can you do during a panic attack? You will speak clearly and firmly. You will not restrict this client. If they need to walk, if they need to move, you'll walk alongside with them. You won't restrict them, because if you do that, you're going to add to the panic and possibly be hurt in the process or hurt someone. Use short, simple sentences. Absolutely. Remain calm and serene. I hope you always do, but especially in this situation. And teach cognitive restructuring. Hugely beneficial, but not when a person is having a panic attack. So that would not be correct. So I hope that helps you get a sense of this, what's expected. And I will post this. And if you have any questions, please, please, please email me or talk to me. And I wish you a good evening.